Hello folks, today we will be talking of a very important topic, that is the scalp. This topic usually comes in the theory as a 10 marks question, and often many questions are asked in the practical exam also from this scalp. So this is whole theory part that we will be talking of, covering the practical questions and the notes of the theory also. So we'll take one by one. So I will tell you what we are all going to talk of. So we'll be talking of the extent of the scalp, from where it starts, where it arises, from where its origin is taking place, and inserted or finishes over which area. Then we will be talking of different layers of the scalp, right? So basically the layers are 5. We'll be talking of all these layers one by one, covering their applied aspects also and the important viva point of questions. Then we will be talking of the blood supply of the scalp. In the blood supply we'll be talking of arterial as well as venous drainage of the scalp, right? And lastly we will be covering the nerve supply and the lymphatic drainage of the scalp. So these are the topics or the crux of the scalp that we will be covering in today's video. So first of all, what is basically a scalp? It's a soft tissue which is covering the calvaria of the skull, right? It is a thick layer, right? So it's a tissue which is basically a thick layer covering the calvaria of the skull. So first, as I have said, we will be talking of these all points. So first we will be taking extent of the scalp. So for the extent, the scalp in front is attached to the supraorbital region, right? The supraorbital part of your frontal bone, it's attached to that, and behind it will reaches up to the external occipital protuberance. And as we know, external occipital protuberance, on either side we have the superior knuckle lines, right? So it will be extending up to the external occipital protuberance and your superior knuckle line. On the lateral part, it reaches till your zygomatic arch. So this is the extent of your scalp region. That is, in front it is the supraorbital part of the occipital bone. Behind it is reaching up to the occipital, that is the external occipital protuberance and superior knuckle lines. On either side it is reaching your zygomatic arch. Now we will be taking the layers. So for the layer, a very beautiful mnemonic is there, that is letters of your scalp. S, that is skin. C, which is connective tissue. A is the aponeurosis. L is your loose aponeurotic layer, and P is the pericranium. So for the layers, a beautiful mnemonic is there, that is SCALP, right? So you have to remember the layers of the scalp, which usually comes in the theory or the viva. So we will be talking of layers one by one. So first of all, the skin. It is a thick skin. As we know, skin is basically of two type. One is your thick skin, the other one is the thin skin. So it is the thick skin which we will be encountering in the scalp region. But it is that kind of thick layer which has got hair, sebaceous gland and sweat glands. But before that, you must be aware of that it's the thin layer where hair and sebaceous glands are present, and in the thick layer you will find the sweat gland. But in the scalp, it is a thick layer where you will encounter all the three appendages, that is your hair, sebaceous and sweat glands, right? So as there are sebaceous glands, so it's a common site for sebaceous cyst formation. So this is one of the applied that can come in the exam, that is the common site for the sebaceous cyst formation. Now the second layer over here is your connective tissue. So for the connective tissue, as we know, C for connective tissue. So for the connective tissue, which is your second layer of the scalp, what kind of connective tissue we have? It's the dense subcutaneous tissue. It's a dense connective tissue which contains the blood vessels and the nerves, right? So basically, what is the function of this connective tissue? It is going to connect the upper layer, that is your skin, to the layer below, which is your aponeurosis, and is going to firmly connect these two layers. That is the function of your connective tissue, right? Talking of the applied, so first applied is, as we have said, it has got lots and lots of blood vessels. So the walls of blood vessels are very tightly adherent to the network of the fibers which is present in this layer. So which is going to do what? So it is going to do what is, whenever the blood vessel is torn, whenever there is an injury, so what is going to happen? The vessels are not going to retract back, which will lead into the bleeding, right? So this is one of the very important questions that examiner love to ask, why there is profuse bleeding if there is injury on the scalp. So it is because of the blood vessels, as the wall of the blood vessel is tightly adherent to this fiber. So whenever there is a cut, it does not retract back, leading into the profuse bleeding. So how we are going to arrest this bleeding? So for that, we have to put a pressure against the bone. So this way we are going to reduce the bleeding of the patient. Second applied over here is that this is your subcutaneous hemorrhage. So whenever there is going to be hemorrhage, what kind of hemorrhage is going to occur? It is going to be localized hemorrhage. It's going to be very painful because the nerve supply is very rich and the swelling is going to be very minimal. So because of the unyielding nature of the fibers, this hemorrhage is going to be the localized and little swelling is going to occur. Third applied related to this second layer is that whenever there is going to be avulsion of the layer of the scalp, whenever there is the injury which is leading to avulsion of the layer, this can be reconnected back. Why it's so? It is because the blood supply is very rich. So whenever you are going to stitch back, it will get connected. So this is the reason why the scalp layer can be sutured back, because of the rich blood supply. So this is the important applied which is related to the second layer, which is the dense connective tissue, or you can say it's C for connective tissue. Now taking over your third layer, which is your aponeurosis. So CALP, so we'll be talking of A over here. So aponeurosis has got two parts. One is the muscle which is present in this layer. The other is the aponeurosis of that muscle. So we'll be talking of two muscles over here, that is Occipitofrontalis muscle and temporophytalis muscle, and the aponeurosis is the Galea Aponeurotica. So we'll talk of muscles first, taking your Occipitofrontalis muscle. So this muscle has got two bellies. One is your occipital belly, the other one is the frontal belly. So this frontal belly is lying in front and the occipital belly is lying behind. And in the center, this is your frontal belly, this is your occipital belly. So in the center, they are connected by the Galea Aponeurotica, right? So they are connected by the Galea Aponeurotica in the center. The other name for Galea Aponeurotica is your epicranial aponeurosis. Talking of the occipital belly first, so we will be talking where this muscle is taking origin, or where, and we know where it is reaching. It is reaching up to the Galea Aponeurotica, and it is supplied by which nerve? So for the origin, as we know, it is arising from the behind, so it is taking origin from your lateral 2/3 of your superior knuckle line. So if I draw, this is my external occipital protuberance, this is my superior knuckle line. So this is the lateral part, lateral 2/3 from where it is taking origin, right? So it is taking origin from the lateral 2/3 of your superior knuckle line, right? So it is going in front, and on the lateral side we have a mastoid process also. So the fibers are taking origin from this process also. So it is taking origin from two parts, and in the center it is reaching your Galea Aponeurotica. This is supplied by the posterior auricular branch of facial nerve. So this is a motor nerve, as we can say. Why it is motor? Because it is supplying the muscle belly. So it is a motor nerve. So the nerve is posterior auricular, which is a branch of facial nerve. Talking of the another muscle or another part of occipitofrontalis, that is the frontal bone. So the frontal bone has got no bony origin, which is again making a very important point over here, that it has no bony origin. Then from where it is coming? It is coming from the skin and subcutaneous tissue of your eyebrow. If I say this is my eyebrows and this is my root of the nose, so it is coming from this region, right? So it's taking origin from the skin of the eyebrows and the root of the nose, and the supply is temporal branch of your facial nerve. So it is also again going to be the motor branch, as it is supplying your muscle belly, right? So what is the action of these muscles? So it has got two functions over here. So if alternate contractions are going to occur for both the muscles, then the entire scalp is going to move front and backward if the alternate movements are going to occur. But for the frontal belly, it is going to, if the frontal belly is going to act alone, what is going to happen? So it can raise your eyebrows. As we said, they are taking origin from the eyebrows, so it will raise the eyebrows if it is acting from the above, which can be in the case of surprise. Or what can it do if it is acting from below? It can cause the transverse wrinkles over here, which is in the fright condition. So this is the function of the frontal belly. Now we will be talking of second muscle, which is temporoparietal muscle. Temporoparietal. So this muscle is located in between. So we'll have frontalis in front or above. Okay, so this is my frontalis muscle. Below I have, this is my auricle, I have two muscles over here, which is my auricularis anterior and auricularis superior. So basically it is lying in this area over here. This is my temporoparietalis muscle. So it is located in this region, that is, above I have got the frontalis muscle, below I have got two muscle, that is auricularis anterior and auricularis superior. So in between I have got temporoparietalis. For the origin, it is arising from the Galea, as we know, the frontalis in front, occipitalis below, and in the center I have got Galea. So here it is taking origin from the Galea. For the insertion, this is my auricle, so it is basically inserted into the root of the auricle. What it is going to do, it will pull the fibers are going to pull it like this, so it's going to raise my auricle, right? And for the supply, it is the temporal branch of facial nerve, which is again a motor nerve. So this is my temporoparietalis muscle. So we talked of temporoparietalis muscle and fronto-occipitalis muscle. Now we will be talking of aponeurosis. So I'll repeat once again. So our layer which we are talking of is the third layer, which is the aponeurotic layer. Basically it has got two parts, muscle and the aponeurosis. In the muscle we have talked of occipitofrontalis muscle and temporoparietalis muscle. So this has got occipital part and the frontal part. Here we have talked of this muscle where it is lying, nerve supply and everything. I will be taking the aponeurosis part. So aponeurosis, I have said, it has got two names. One is the Galea Aponeurotica and the other one is epicranial aponeurosis. So these are the two names we can call it. So never forget these names, as we can interchange these names with each other. So what this aponeurosis is, it's a sheet of fibrous tissue which is going to connect two muscles over here, that is frontalis in front and occipitalis behind. So we are going to have this aponeurosis in the center, which is going to connect these two muscles, occipitalis in the front and frontalis in front and occipitalis behind. Coming on to the attachment of this aponeurosis, so behind what we have in the center, that is the part of occipital, which is external occipital protuberance, and on either side now we have the highest knuckle line, which is just above your superior knuckle line. So it is attached to this region. So what we can say, behind it is attached to external occipital protuberance and the highest knuckle line. In front, where it is going to blend with the root at the nose. So I have got the eyebrows over here. This is going to be the nose. So here it is blending, right? And I know the frontalis muscle is lying on either side. So what I have in the center is my aponeurosis. So it is going to blend with the subcutaneous tissue at the root of the nose. Where it is going to reach on either side? Obviously, there is a zygomatic arch where it is going to reach. So this is my attachment for the Galea Aponeurotica, or I will call it as epicranial aponeurosis. Now coming on to the important applied aspects. So as Galea is a fibrous sheet, it is very sensitive to pain. Another thing that will happen over here is the wound of the scalp, they gape whenever we are going to cut it into the transverse fashion. So it is going to gape over there. Now coming on to the another layer, which is your loose subaponeurotic layer. Now this is my fourth layer. This layer is very important, as many clinical questions arises from this layer. This layer is called the dangerous layer also. This layer is called the safety layer also. So we'll see why we have got two different names for this layer. So first of all, what is this layer? It is a loose areolar layer. Loose means it has got a space, it has got plenty of space over here. Another important thing is it has got very important structure, that is the emissary veins. These veins do not have valves. So what these veins are going to do, so this is my scalp, this is my intracranial area, this is my extracranial area. So these veins are going to connect my intracranial venous sinuses with that of my scalp region. So that's why emissary veins are going to play very important role over here. So now we will take the applied one by one. First of all is the fourth layer is called dangerous layer of the scalp. So why it is called? As we have talked that the emissary veins, they do not have valves. What they are going to do is they are connecting the intracranial sinuses with the extracranial part, right? So if there is any infection outside, it is going to spread inside to your through the intracranial sinuses, right? So that's why we call it as dangerous layer. So fourth layer is called the dangerous layer. It is going to spread the infection to your intracranial sinuses. Another important part is the black eye. So now what is black eye? Black eye is basically the blood in this space is going to produce the swelling. Now the swelling is going to be generalized swelling, right? Why it is going to happen? As it is going to gravitate your eyelids, the blood is going to gravitate into the eyelids, as there is no bony attachment of the frontalis muscle leading to the black eye, right? So as there is no bony attachment, the blood is going to reach into the eyelids leading or causing your black eye. Now third applied over here is the fourth layer has got another role, that is safety valve hematoma. So why we are calling it as a safety valve hematoma? So there is a theory behind this part also, that whenever the vault is going to get fracture, there is going to be a tearing of dura and the pericranium, right? And the hemorrhage is going to occur, which is the intracranial hemorrhage. So there is a fracture of the vault, the vault has been fractured, so the hematoma is formed over here. Now what it is going to do is the blood is going to seep out through this fracture, leading or going into the fourth layer until this layer is filled. It will lead into the subaponeurotic space. So there will be no signs. So this is my brain. So there will be no sign of cerebral compression. So that's why it is also acting as a safety valve hematoma. So this is the reason of why this is called the safety valve hematoma. Now talking of another applied, which is cephalhydrocele. So it is seen in children, cephalhydrocele. So hydro means it has something watery, which is a swelling which is going to contain the cerebrospinal fluid. Now another thing over here is caput secundum. It's also seen in newborn whenever there is a normal delivery and a baby is passed through the birth canal. So what is going to happen at that time? There is going to occur a temporary edema through this passage because of the venous return. Because the venous return is interfered over here. So due to interference, this venous return leads to the temporary swelling, which is known as caput secundum. Now talking of our last layer, which is your pericranium. It is loosely going to cover the bones and it is not present at the suture line. So what it is going to happen over there is it is going to continuous with the inner layer, which is your endocranium. Talking of the applied, so whenever there is going to be any fluid collection, it is going to present with the localized swelling, and that swelling is going to take the shape of the bone to which it is related. So that's the fourth layer, which is your pericranium. So all the 5 layers you have to remember, and the applied, which can come as individual questions also, applied questions also, or in the practicals. Now we will be taking the nerve supply. So for the nerve supply of the scalp, you should remember that there are 10 nerves on each side. So if I draw, this is the top view, you will divide it into 2 halves. So you'll have 10 on this side and 10 on this side. Now what is going to happen, this is my auricle if I say. So I'm going to have 5 in front of my auricle, 5 behind my auricle. Same over here, 5 in front and 5 behind. Now among these 5, again I'm going to have 4 sensory and 1 motor. 4 sensory, 1 motor. 4 sensory, 1 motor. Again over here, 4 sensory and 1 motor. So this is basically the nerve supply. So we'll taking all the nerves one by one. So the names of the nerves are like this. So on the front I am going to have supratrochlear, supraorbital. 2 supras over here, supratrochlear and supraorbital. Now another 3, these are the one which are in front of the auricle we are talking, right? Another 3 are temporal, right? Another 3 are temporal. 2 over here are supra and 3 over here are temporal. Easy to remember. So what are these temporal? It is zygomaticotemporal, temporal branch of facial nerve, and auriculotemporal, right? If we talk of the nerves which are behind your auricle, behind auricle, as I've said, they are also 5, right? Among that 4 are going to be sensory and 1 is going to be the motor. So behind what we have is the 2 auricle and 3 occipital. So 2 auricles are posterior branch of great auricular nerve, posterior auricular branch of facial nerve, and 3 occipital are lesser occipital, greater occipital and third occipital. So we have 2 auricle and 3 occipital over here, right? So among these, as I have said, 4 are going to be the sensory, right, and 1 is going to be the motor. So motor in front is going to be your temporal branch of the facial nerve. So if you remember, this is the one which is going to supply your frontal muscle. And behind what we have is the posterior auricular, which is also the branch of facial nerve. This is the motor nerve. This is supplying your occipital muscle, right? So these are the 10 nerves which are going to supply the scalp. Now we will talk of arterial supply. So for the arterial supply, you just have to remember that there are 5. So if I say this is the topmost view of my scalp, so I am going to divide it into 2 halves, 5 on this side and 5 on this side. And if these are my 2 auricles, I am going to have 3 in front the auricle, 2 behind. 3 in front of my auricle, 2 behind. And all the arteries which are going to supply the scalp are taking origin from internal carotid or from the external carotid. So you will see a beautiful combination or anastomosis between the external carotid and internal carotid artery. So we'll talk of the arteries over here. So in the front, I'm going to divide it into 2 halves, right? So in the front I have supratrochlear, supraorbital and superficial temporal. So I have 3 S over here. And behind the ear I have got 3, that is posterior auricular and occipital. So PO, yeah, OP I can say behind my auricle. So out of these 5, first 2, that is supratrochlear and supraorbital, they are the branch of internal carotid. Which branch of internal carotid? Ophthalmic branch of internal carotid. Rest all the 3 are the branches from your external carotid artery. So a beautiful anastomosis is seen between your internal carotid and external carotid. Now lastly, coming to the venous drainage. Venous drainage, you just have to remember a beautiful W over here, right? This is the W that is formed. So what is happening over here is the 2 veins, that is your supratrochlear and supraorbital, they are going to join and form a vein in just at the medial angle of eye, that is your angular vein, which is going to continue as a facial vein in front of your, that is just behind the nose, then the angle of the mouth, right? That's the facial vein. Here we have the mandible, ramus of the mandible. Just behind the mandible you are going to see another vein, that is your retromandibular vein. So retromandibular vein is formed, or it is going to receive the drainage from 2 veins over here. One is your superficial temporal, the other one is your maxillary. So as the retromandibular vein comes close to the auricle, it is going to divide into 2 divisions. One is the anterior division, the other one is the posterior division. So the anterior division is going to join with your facial vein, forming a common facial vein over here, draining into your internal jugular vein. Whereas the posterior one will join with the another vein which is just behind your auricle. You will call it as posterior auricle. This will join with the posterior division, forming the external jugular vein, finally reaching into the subclavian vein. So this is the venous drainage. Last but not the least is the lymphatic drainage. So we'll divide the lymphatic drainage into 2 parts, anterior part and the posterior part. So anterior part is draining into the preauricular part, or you can call it as parotid lymph nodes, and the posterior and to the postauricular, or you can call it mastoid and occipital lymph nodes. So this is the lymphatic drainage. So we have talked of all the important questions of the scalp, right? We have talked of the layers individually. We talked of the blood supply covering your arterial and venous. We have talked of nerve supply and the lymphatic drainage. That's all. Thank you.